I have the pleasure of introducing our speaker today, Dr. Julia Berian. Dr. Berian is an assistant professor of surgery in the Division of Colorectal Surgery at the University of Wisconsin in Madison. And Dr. Berian completed her medical degree and surgical residency at the University of Chicago and graduated from the Colon and Rectal Surgery Fellowship at the University of Minnesota. She completed a research fellowship as the James Thompson Geriatric Surgery Research Fellow at the ACS during her residency and contributed to the development of the ACS Geriatric Surgery Verification program. She earned her master's degree in health services and outcomes research from Northwestern University as well during that time. Dr. Berian joined the faculty at UW Madison in 2020, and her research is supported by an NIA K23 award, which aims to improve surgical care for older adults by applying systems engineering and implementation science methodology to perioperative care. We're really pleased to have you join us here today, Dr. Berian, to the Colorectal Surgery Virtual Education Series. Thank you.
Thank you so much, Dr. Lee. Very happy to join and talk about a topic that I care a lot about. So I was asked to discuss geriatric considerations in colorectal surgery, and I'll start with a couple disclosures, which is that I'm not a geriatrician, even though I've done a fair amount of aging research. As was mentioned in the bio, my research is supported by a Career Development Award from the NIA. And, I think also relevant to this talk is just that I did previously work for the ACS, and I helped develop the standards that eventually became the Geriatric Surgery Verification Program, or GSV. But I have no other relevant financial disclosures. So just as an outline, when I was asked to discuss, geriatric considerations in colorectal surgery, it kind of took me back to think about, well, what really are geriatric principles and how are they relevant in colorectal surgery? And we will talk about that, but I'm really going to highlight some important topics and a couple of favorite papers in regards to frailty, physical function, cognition, and then decision-making for the older adult. So geriatric principles, there are, entire textbooks. Obviously, geriatrics is an entire specialty field in and of itself. But I would say, the two kind of underpinnings for me, at least, are the recognition of how aging itself influences the physiology across different organ systems. But then at a higher level is really just the application of kind of biopsychosocial approaches to care. And I'll explain a little bit about what I mean by that. So, I mentioned physiology. Obviously, aging alone without comorbid conditions will influence different organ systems function. But in addition, as we age, we tend to accumulate different comorbid conditions. Those are treated with various medications, which can lead to polypharmacy, different interactions, and potentially inappropriate medications, particularly for the older adult. Then, there's a consideration of someone's physical function beyond just their cardiopulmonary risks. What is their actual physical function? What's their mobility like? Have they had any falls? Are they independent in their ADLs and their IADLs? Which are activities of daily living, if you're not familiar. And then consideration for mental function, basically not only cognition and kind of brain function, but also mood and how that plays in, since there are many older adults who have under-recognized depression. All of these factors play into decision-making and different recommendations for treatment for older patients. And then behind all of this is, of course, social support structures and the physical environment. So this is sort of what I meant by the biopsychosocial approach to care, is that I think geriatrics in particular does a very good job of incorporating not only what we typically think of as medical problems and comorbidities, but also trying to place the patient in a more person-centered context of kind of who are they and what influences everything else related to their care. So one of the kind of gold standards for geriatrics is a comprehensive geriatric assessment. And I will say that, this is not my term. This has been used in the literature for more than 40 years, and it's really more than an assessment. So, I didn't name it, and I sort of hate the name because it really implies that it's just a test. But most of the time, a comprehensive geriatric assessment should be a comprehensive, interdisciplinary, multi-dimensional, really model of healthcare delivery for frail older adults. And it should be able to identify deficits across different domains and often recommend interventions to help improve any of those deficits. So this is from a review within the geriatrics literature, covering different domains of the comprehensive geriatric assessment. And I'll point out that some of these are defined slightly differently than how I framed them a couple of slides ago. But, many of them are similar and have crossover. It's a pretty, I would say, consistent set of domains that go across the literature. And what you'll notice when you look at this list is, as I mentioned, mental functioning, physical functioning, and then they have their own category of functioning, but just sort of functioning in the world, social circumstances and environment. I would argue that this is sort of an original appreciation for social determinants of health, which have recently become a very popular area for research and understanding all of those previously unmeasured factors that do contribute to outcomes for our patients. So, I mentioned for geriatric considerations in colorectal surgery that, there are all these different domains. I'm not going to cover all of these. There are, many different resources that one can go to. So, I'm really just going to sort of focus on a couple of them. And I would say that, the 4 categories that I'm going to talk the most about are cognitive function, physical function, frailty, which I think really encompasses all of this, and decision making. So how is this relevant in surgery? Really surgery in general, in addition to colorectal surgery. So this is a great cartoon from the New Yorker that says, yes, it's a routine procedure if you routinely have someone slice open your body with sharp instruments and then fiddle with your insides, which is sort of how our world works, right? So, even among healthy older adults, their aging physiology will affect their ability to recover from a major surgery. And this is where I'll just sort of give a nod to some of those physiology related changes that I mentioned. This comes from the perioperative management of the geriatric patient, which is a best practice guideline from the American College of Surgeons, which was developed in concert with the American Geriatric Society, and was actually the scholar before me in the line of geriatric research fellowships. And you can see on the slide, there are changes that happen over time in cardiovascular physiology and pulmonary physiology, and all of these things will inevitably have an effect on recovering from surgery immediately in the operating room, in the PACU, in the days that follow in the postoperative period, and then also over time. So I'm not going to go into too much detail on this. There are lots of textbooks you can read if you're interested. So I will just sort of start by saying, on average, 25% of older adults, somewhere around a quarter of them, will develop some sort of postoperative complication from elective surgery. That's planned surgery. Certainly unplanned emergency or urgent operations, carry a really high risk. But even when we are doing our best to plan everything out, there are high rates of postoperative complications. So, and that estimate comes from a meta-analysis of multiple different studies, thousands of patients, and multiple different planned elective procedural types. So, if you take a look at these photos, right, a picture is worth 1,000 words. So when you have two people who may have similar ages, you can tell just from the photo that their physical function and therefore their underlying reserve will be different. So from that same meta-analysis and review, they outlined a few geriatric specific factors, which kind of fall into the domains I was discussing. So frailty across studies increased risk for postoperative complications about twofold. Cognitive impairment was similar. Depressive symptoms also significantly increased risk. And smoking, I would say, is something that as surgeons we generally screen for. But across all these different domains, they were really increased risks, and many of them are rarely measured and even less frequently addressed or optimized in any way, other than perhaps smoking. But even that is really a little bit difficult when you're dealing with things like cancers. When we think about these different domains, I'm going to start first with frailty because I think that that is kind of an umbrella of geriatric domains. So, once again, there's an aging component here, just another silly cartoon about, your doctor can only do so much, and aging itself poses some risk, right? So this review is one of my favorites by Tom Robinson. It's called Frailty for Surgeons. And it was essentially a 2-day conference that was convened by the NIA and the AGS to discuss the state of frailty research and its relevance to specialists. Part of the reason I really love this paper is that it has this great figure which helps explain what exactly is frailty. And in panel A, you'll see that there is some intrinsic thing that is this biologic-driven frailty. This is really characterized by what we would call the frailty phenotype, which was developed by Linda Fried. And it is really characterized by some of these more kind of physical elements like walking speed, weight loss, physical activity, muscle strength, energy level. But essentially, the idea is that frailty is something intrinsic that happens with aging and is a biologically driven phenomenon. And the effect is manifest in some of those physical characteristics, slow walking speed, weight loss over time, loss of muscle strength, physical activity, low energy, et cetera. And then in panel B, you can see a kind of a different framework, which is the idea that of accumulation of deficits. So it's kind of this deficit-driven model of frailty. Ken Rockwood's work in geriatrics really kind of popularized this idea of frailty in relation to accumulating many deficits across different comorbid conditions and domains. And so here you have all of the arrows directed inward, that the combination of different social vulnerabilities and medical conditions, and maybe some functional decline, perhaps a mood problem like depression, or cognitive changes or poor nutrition, are all contributing to create the phenomenon of frailty. So for each of these domains, I wanted to try and give something useful. This paper on its own actually has a toolbox of frail measures. And so in it is highlighted one of my personal favorites, which is called the Frail Scale. It's just 5 items. This is the entirety of the scale right here on the screen. And so it's questions related to fatigue, resistance, ambulation, greater than 5 comorbid illnesses, and greater than 5% loss of weight. So, there are a lot of different frailty assessment tools, and they are all variable in terms of the resources required to implement them, and the duration that it takes to do the testing and assessment. But whenever I get texts from friends or colleagues asking, which one should they do, at least, especially when you're kind of starting out in this work. This is one of the ones that I recommend people look into. So I wanted to also acknowledge that our own specialty has our own guideline on evaluation and management of frailty for older adults undergoing colorectal surgery. And this was written by Nicole Sauer, who's fantastic. And it's really an incredible, thorough review of almost all of the domains that I'm talking about today. In fact, I probably should have just told you guys to invite Nicole Sauer and have her just go through the guideline because it's really very thorough. But I wanted to at least pepper this presentation and conversation with some of the formal recommendations that have come out of the CPG from our society. So with regard to frailty itself, the recommendations from this guideline are, treatment recommendations regarding colorectal surgery should consider patient's degree of frailty rather than chronologic age, sort of those two photos I showed side by side. And then second, that frailty screening in the ambulatory setting identifies vulnerable and frail older adults. In other words, like if you do this screening, you will inevitably identify the highest risk patients. And so both of those were strong recommendations based off of high quality evidence. So next I will talk a little bit about physical function. And I think, frailty was a good starting point because it does sort of encompass physical function, often incorporates some sort of cognitive screener, and is really kind of an overarching category. But I think physical function is worth paying specific attention to. Again, a funny kind of we're getting old, can't chase the cat anymore, Far Side cartoon. So this is one of my favorite papers when it comes to physical function and recovery for older adults, by Valerie Lawrence, published in JACS in 2004. By now kind of a dated paper, but still was one of my favorites when I started looking into aging research. And this was a prospective cohort study of 372 patients aged 60 and older. And what she did was to do pre-op and then a series of post-op assessments for patients having surgery across 2 different private practices and a couple of academic institutions, all of whom were having major abdominal surgery. Now, this was done in the late 90s, so they were all open operations, a variety of colorectal, aortic, upper GI surgeries, et cetera. And the findings were that almost every domain, almost every outcome dipped at a week post-op, which we would expect. But what was really interesting is that there were many outcomes that never fully recovered, and that there were a significant proportion of patients who really had a protracted recovery period across different domains, including some of their ADLs and their IADLs. So here is grip strength, which I found particularly remarkable, that, many patients had not recovered their grip strength by 6 months post-op. And then in addition, the panel on screen right is looking specifically at activities of daily living and independent activities of daily living, instrumental activities of daily living, which really helps assess for kind of independence in daily life. And you'll see that things like walking, bathing, dressing, really kind of at that nadir of the graph here. Those are all things that do require recruitment of multiple large muscle groups and coordination. And those really did take a significant hit. And in addition, that they really were very slow to recover, with a number of patients staying dependent at, 3 weeks, 6 weeks, 3 months, and 6 months post-op. And then very similar, that even among IADLs, which we would sort of assume may recover quickly for most patients, you'll see on the graph that there were a significant proportion that had dependence even in some of these IADLs. Again, things like housework that require a lot more physical endurance were affected the most. So one of my mentors, Dr. Rosenthal, who has done a ton in this space of geriatric surgery research, likes to point out that that bed rest is really just a huge detriment to our patients, and that the emphasis on trying to prevent falls in the hospital actually has an unintended consequence of keeping people in bed too much. These are a couple of papers that come more out of kind of the physiology, nutrition type literature, which is talking about, loss of almost 1 kilogram of lean leg muscle mass after bed rest for 10 days. And this was including healthy patients as well, which translated into somewhere around, 11 or 12% of the power and strength for their knee extension. Those are a couple of specific numbers, right? There are any number of quotes you can find about, for every day of bed rest, it takes 3 days or 7 days or however many days to regain lost function. I've not been able to pin down a good solid number, but I think it's very clear that for every day of complete bed rest, it does take multiples to fully recover. And I think that's worth thinking about for our patient population. So one of the findings out of the Lawrence paper is just, that patients who had better preoperative function inevitably had better recovery. And so then the question is, well, then can we prehabilitate people? And is the answer, is the tool that I'm going to recommend to you all, is it, prehabilitation, prehab? In our CPG, I think, I have friends in the aging research realm that think that this clinical practice guideline was actually a little too strong in our language, but I think it was pretty reasonable, which is that frail older adults may benefit from preoperative multimodal optimization, which is prehab. And they called it a strong recommendation based off of moderate quality evidence, which I would agree with. There are any number of meta-analyses out there about prehabilitation. The challenge is that the literature is just very heterogeneous. So the interventions themselves differ in the content, the type of exercise delivered, whether it's strength, endurance, aerobic activities, the modality of delivery, things that are observed, coached, independent exercises, the duration, how long these exercises have to be done, the frequency, the intensity, et cetera. So it is difficult to assess this literature. The outcomes that get chosen are all somewhat different. And I think in addition, there's a lack of detail about exactly how some of the interventions are given or delivered. But I do think it's important to recognize that there is a signal here, and that is typically more apparent when looking at functional capacity outcomes. So, for example, here, this is out of one of the more recent meta-analyses that's looking at the 6 minute walk test. And you can see that overall, the figure favors prehabilitation, favors some effect for improving functional capacity for patients who did participate in prehabilitation. There was a really well done randomized controlled trial by Carly that was actually no significant difference. But one of the interesting secondary analyses that their group did was an analysis of the older frail population, identifying that those who could not attain a 400 meter 6 minute walking distance suffered more postoperative complications. So it's very interesting that 60% of this prehab group really didn't reach a minimum 400 meter walk. And that difference is nuanced enough that there wasn't a significant difference in the frailty phenotype between those two groups, those who did and didn't reach that 400-meter walk. And then just for some back in the napkin calculations, 400 meters, approximately a quarter of a mile. So you're really thinking about a walking pace that's about 24 minutes for a mile. And it gives you at least some way of conceptualizing like how much our patients should be able to walk. So, the tip here, I wish that I could be more specific, except to say that it's really important to tell your patients to move. It comes from a physician, it comes from their surgeon, and they do take recommendations seriously. And so I know surgeons who say you wouldn't run a marathon without training. And so therefore treat your surgery like you would treat a marathon. You have to train for it. Actually, our chair tells her patients that before Whipples, and they do take it seriously. So, even though the data are mixed, they do suggest a benefit, and there's really no magic number, but maybe consider 400 meters to be the floor of where patients, what patients should reach before they do an operation, and that more is probably better. So, moving on, we'll talk a little bit about cognitive function next. And there's a lot to say in this space. And I think this is probably the area where we as surgeons, and certainly in colorectal surgery, it isn't really baked into any of our processes right now. So this is just a Far Side cartoon of Superman in his later years, forgetting where he was going. So for cognitive function, older adults really are at risk for postoperative delirium. In addition, they're at risk for longer-term cognitive decline. So just to put in a word for some of the nomenclature, this is now called perioperative neurocognitive disorders. For those that remember the term postoperative cognitive dysfunction, that really had no consensus definition, and it was primarily used for research and was sort of there needed to be a more of a consensus on how to define some of these disorders. So the ASA actually convened a conference in order to better kind of discuss the state of the science for perioperative cognition. And they came up with a nomenclature, which is published and available. I'm sorry that I don't have it on the slide, but really tried to align some of the terms we use to things that are used in medicine, in geriatrics, as well as in psychiatry, like using the DSM. So these are the current recommendations, is that you call it perioperative neurocognitive disorders. And that's typically for prolonged changes in cognition after a surgery. There are the shorter term within 30 days, I believe, is delayed cognitive recovery. And then postoperative delirium is still delirium. So, by doing preoperative cognitive screening, we can identify patients who have pre-existing cognitive impairments or deficits because they are those at highest risk for delirium. We can counsel them better and educate their family members. And I think that's really key to providing a better experience for the patient and their family. Hopefully we can prevent episodes of perioperative neurocognitive disorders. We can certainly prevent severe episodes of delirium through multimodal non-pharmacologic interventions, which I'll show you a Cochrane review about that. And then in addition, we can connect patients and families with resources just simply by knowing about concerns for someone's cognition. We are better able to circle that back to their primary care, potentially connect them with memory clinics in the future. So, this is by now somewhat dated Cochrane review of interventions to prevent delirium in hospitalized non-ICU patients. And it did include patients from surgical trials in addition to medicine. There were 39 trials and 16,000 patients included. And the multi-component interventions overall reduced the incidence of delirium compared to usual care by a risk ratio of about 0.7, so somewhere around 30%. They also examined the evidence for things like cholinesterase inhibitors and antipsychotic medications and melatonin, and there was no clear benefit to those. So this is just sort of their forest plot for the trials that are looking at multi-component delirium prevention interventions compared to usual care. And as I pointed out, this ratio here is somewhere around 0.7, which is about 30% potentially preventable. And that's pretty consistent across other studies as well, is that somewhere around 30% of these episodes are going to be preventable. These multi-component interventions, as I mentioned, often involve individualizing care, providing more education, doing frequent reorientation, early mobilization, normalizing sleep-wake cycles. And they even put in the review that many of these delirium risk factors that are targeted with the multi-component interventions really relate to good basic care. Oftentimes, delirium prevention is nursing-led initiatives, and it really does require participation from lots of different staff and allied professionals in addition to the surgeons themselves. And so this is a really good type of an initiative to be involved in from a QI standpoint in whatever job that you end up in. But it's important to prevent delirium because there is actually an association with long-term cognitive decline, and there are more and more papers about this in recent literature. So this was a JAMA neurology meta-analysis that included 24 different studies, again, including surgery and non-surgery groups. They created some pooled effect estimates and found a significant association between delirium and long-term cognitive decline. Essentially, patients who experienced delirium had 2.3 times the odds of cognitive decline versus those who did not. Here's sort of their forest plot there. But one of the things that I really like about this paper is that they also address the idea that postoperative delirium is an epiphenomenon, that essentially the patients who develop delirium had some underlying predisposition. In other words, that there was something about those patients where they would decline faster no matter what, even if they didn't get delirium. And so they specifically pull out a few papers that were done among patients who did have pre-existing dementia, demonstrating that even in the context of pre-existing dementia, delirium accelerated decline, which I think is really important to understand. So the CPG for our society says that cognitive function should be assessed preoperatively in frail older adults. I want to make a quick note that cognitive screening is not the same as making a true diagnosis of a cognitive impairment. So diagnosing someone with dementia or cognitive impairment does require multiple assessments over time, and dementia specifically requires some degree of interference with functioning. But I think that this model of cognitive decline is really helpful to think about the fact that patients start at different points along these curves, and we don't know necessarily where they are, but that some additional insult, namely a surgical intervention, could potentially shift people down a line, and that we may play a role in their cognitive trajectory that we are not always aware of. So if you have a brain, you're at risk for dementia. And so it's valuable just to establish someone's baseline. If you look at using CMS criteria, then using someone age 65 and older kind of makes the most sense. Otherwise, you could say, well, you want to screen those who are the highest risk. You could start doing frailty screens, and then among those who screen as frail, then do further cognitive screening on them. So I don't really know the answer, except to say that it has to be feasible. And so wherever you end up and whatever you end up doing, if you're interested in starting to screen your patients preoperatively, that you really have to work within your system and figure out what makes the most sense. The American Academy of Neurology actually does have suggestions for using cognitive screening as a quality indicator. So there may be opportunities to partner with other groups. And then, I guess I would say that ideally we should be screening everyone 65 and over who are having major surgery, but we're not quite there yet. As far as practical tips go, this review I found incredibly helpful. It's a review of screening for mild cognitive impairment in the preoperative setting. And one of the things that I particularly appreciated about this review is that they cover, they were quite specific about which domains of cognition are assessed in different screening instruments. You might expect, memory as a domain itself, excuse me, is commonly included, which makes sense because amnestic mild cognitive impairment is the subtype most commonly associated with progression to Alzheimer's or related dementias. So most screeners include a memory domain. They reviewed anything that could be done in 15 minutes or less. And also included information about how it was validated across gold standard neuropsych testing, which I found really helpful. And then they documented some of the sensitivity and specificity for mild cognitive impairment, which I also thought was helpful. This is particularly important since we aren't really looking to screen for dementia per se. We're just trying to screen for people who would have a higher risk of postoperative delirium, and that would be anyone with MCI and above. So these were some of the tools that they called out in that review, which I encourage you to check out. The mini cog is common. It's a 3-word recall and a clock draw. It takes about 3 minutes. And you can see there the sensitivity and specificity for mild cognitive impairment. The Ottawa 3-day year is also common, which is the day, the date, and then asking them to spell world backwards. And then, of course, there's the slums and the MOCA, which are a little bit more extensive. So then finally, I think it's worth talking a little bit about decision-making in geriatric surgery. And certainly as we age, perspective changes and the decisions that you make may change. This paper is just a really, I think, kind of important seminal paper when it comes to decision-making for older adults with serious illness, from Terry Freed in 2002 in the New England Journal. She took 226 patients, 60 years and older, who had some limited life expectancy due to either cancer, CHF, or COPD. And she presented them with different hypothetical treatment choices and asked them to weigh the burdens of the treatment with the likelihood of certain outcomes, and then to express their preference for those treatments. So you have to sort of understand that methodology and use that grain of salt. But it was, really remarkable that when you move across these different columns, you see that, you know, as expected, most people would like treatment if the burden is low and you're going to restore your current health. And in scenario 2 column, of course, you know, the higher burden of the treatment, as long as the outcome is restoration of your current health, most people also would select that option. But columns for scenario 3 and scenario 4 are really remarkable, that if they're even for low burden treatment pathways, if there is a high likelihood of functional impairment or cognitive impairment, the vast majority of the patients in this study said, no, I wouldn't want that, right? So you're looking at only roughly 0.25% of people that wanted the treatment, 25% or so that wanted the treatment, or even less than that, right? The 7 to sort of 13%, if there was a significant cognitive impairment. So the ASCRS clinical practice guideline says that treatment plans for frail older adults should align with patients' goals of care and should be based on a discussion regarding realistic outcomes. So how are you supposed to do that? Well, I know that this fellows group is going to have a talk from Jess Cohan at Utah about decision making, but no talk on this topic would really be complete without acknowledging the importance of decision making. And so I wanted to at least point out this tool for having those conversations, which it's called Best Case, Worst Case. This is work from Gretchen Schwarze's lab, who is one of my mentors here at UW. And she has really contributed a number of important studies to this literature, looking at how surgeons perceive buy-in from their patients, especially when there's big operations that we expect that they want to pursue everything that we know is involved. And this is a tool that came out of some of her work to help surgeons really better improve those conversations about what exactly is involved in this whole course of care. So it's a pre-post study. This JAMA surgery paper is a pre-post study that was the use of the tool itself, which demonstrated that surgeons improved their shared decision-making according to this observer score, and really shifted conversations more towards outcomes and towards describing the story. So Dr. Schwarze will often use, what's called scenario planning. In other words, giving the whole picture of one scenario instead of giving a number of different statistics of the risk of X is whatever, 20%. So I encourage you to check out the YouTube video on this if you haven't already seen it. So now we have covered cognitive function, physical function, decision-making, and of course, frailty. And, that pretty much covers everything that I wanted to talk about today. But I do want to leave a couple of final tools that are useful as you go forward and establish your practice. So what can you do in your next job? Well, I would say that if you're interested in this, there are, it's a really rich and interesting area for those who want to have a true kind of NIH pathway research career. But in addition, I think it's just a really incredibly important space for us to improve the care we provide to our patients. And so there's really valuable contributions that you can make to any institution. And the couple of programs, formal programs that are out there that I wanted to point out is the Geriatric Surgery Verification program, which of course I have to acknowledge that I helped with the development of this program, so I'm biased towards it. But it is through the American College of Surgeons and is a whole quality program that's really centered on some of these concepts for management of geriatric patients. But if you didn't go that route, another very common and popular initiative comes from the IHI, which is the Age-Friendly Health Systems. And you'll see, again, these are very similar domains, right? So what matters in terms of decision-making, mobility in terms of physical functioning, mentation, cognition, and then medication management, that polypharmacy category that I mentioned. So these are really just two, but are quite large and well-developed frameworks and programs. And then, of course, there are kind of smaller and homegrown initiatives that you can do working with colleagues at your own institution. So with that, I would be happy to take any questions.
Thank you, Dr. Berian, for that comprehensive overview of geriatrics. I know it's a big topic to try to distill down into 45 minutes. And I'm sure that we'll be going back through the recording to look at some of those papers and the guidelines as well. So there were a few questions, and some of it is related to decision making. So we had a few questions from fellows about decision making with like octogenarians and nonagenarians on surveillance and decision making on surveillance for colorectal cancers and pursuing adjuvant therapy. How do you approach these discussions with these patients where there's not a lot of data on outcomes, and then B, sort of taking into consideration what their values and preferences are in terms of counseling and the like. So
yeah,
appreciate your thoughts on that.
Of course, yeah. I mean, I have had a number of those patients myself. And I would say, despite all my research on this topic, I would not call myself an expert yet. I think, it can be really difficult. I would say that the clinical practice guideline does a really great job of explaining why it's important to provide, appropriate goal concordant adapted care to our patients instead of just plowing through with standard of care. So of course you have to acknowledge where you are deviating from known standards of care, and then you have to be able to explain why and what that benefit might be. And so, I pointed out some of the work coming out of Gretchen Schwarz's lab, but, a lot of her current work is really focused on improving conversations between surgeons and patients. And I think about that a lot in terms of explaining, what we hope to get out of surgery, what the goals of the surgery are. And when you have octogenarians and nonagenarians, the first piece of the puzzle is making sure that you do some of those assessments and figure out exactly, what their function is, physical function, cognitive function, et cetera. And then sort of place it into the context of their own goals, right? And then make a tailored recommendation for them and explain why you're making that recommendation. So I'm particularly sensitive to my older adults who come with dementia and underlying cognitive problems, because, in all likelihood, they are at risk for having delirium and having worse cognitive outcomes. And I think one of the things that comes out of this research and out of those guidelines is the flexibility and the permission to be a physician and to use your judgment and to explain to someone what might be an expected standard, like going through the huge APR, and what might be an alternative that will help them, with a better quality of life for the years that they have left. And then I guess the side note here would be, particularly when it comes to cancer care, just that the oncology world has made so many incredible strides, and, you know, the use of immunotherapy is incredibly valuable. So, you know, make sure you do a good, thorough cancer assessment, et cetera, know what their MSI status is, right? Because I've seen a number of patients have pretty dramatic responses.
Yeah.
Yeah.
On that note, you know, with watch and wait protocols as well, and that sort of being an emerging option for some patients, could be considered potentially for this population as well.
Yeah.
And what are your thoughts in terms of approaching ostomy teaching and things that require a lot of dexterity and strength and in geriatric patients? Does that change your decision making on whether to put in an ostomy, or sort of trying to engage the community to help the patient more?
Yeah, yeah, it absolutely does. I mean, I think that I think without doing geriatric focused assessments, you may or may not know that someone would have a difficult time managing the ostomy physically. I think, you know, we are pretty quick to do a diversion in anastomoses that are, you know, low radiated, et cetera. But I think twice about it for the older population, since they're so affected by volume depletion and high output. I think assessing their social support systems and really engaging with your social workers and case managers and trying to get those patients as much help as they can. I think that can be incredibly beneficial. Do that up front. So I think ostomates are a particular subpopulation that are really important for us to pay attention to.
We have a question from Sir John from Subramanian, Dr. Natarajan from Eau Claire, Wisconsin, and he'd like to know if you routinely use frailty screening and cognitive screening in your pre-op note for patients 65 and older.
Yeah. So, so this, I mean, I acknowledge that I am incredibly lucky to be able to send my patients to a geriatrician. So I would say yes, I mean, I do, but it's because I have the resources that I have, you know, in my system to be able to send them to a geriatrician and do preoperative testing. Which is part of the reason that I tried to include in the talk, you know, different tools that you might be able to use that are a little more easily accessible. But yes, I do routinely send my older patients to our preoperative geriatric screening.
Thank you so much for joining us tonight.
Yeah, thank you very much for having me. And, you know, I think my information was in the flyer, et cetera. So please feel free to reach out if there are other questions or you have interest in this area.